Well, today we're going to talk about CRT or continuous renal replacement therapy. Now, the reason I kind of got involved with CRT is we had found over the years, especially in the burn world, that we give a lot of fluids to burn patients. So we needed a way post resuscitation to get the fluids off. And what we had found was with the CRT, we were able to get fluid off. Unlike regular hemodialysis, we weren't messing a lot with the blood pressures and all. So, kind of that's what we're going to talk about today. We're going to kind of talk about the difference between the next stage or the CRT versus the regular hemodialysis that most of us are used to. So, here we like to say that CRT is a more gentler dialysis. I mean, if you think about dialysis, you take blood out, you clean it up, you put it back in, whether it's in a chronic renal patient or whether it's acute renal patient. Majority of the time, what we're doing is we're doing hemodialysis. And if we think about hemodialysis, basically it's all done through osmosis and diffusion. So greater concentration to a lesser concentration, lesser to a greater, just depends on your sodiums, your potassiums, and all the electrolytes that you're running through it. The difference that we run into with CRT is it's basically based off of a different modality. Instead of doing osmosis and diffusion, basically what we're doing is what they call convection. So we're basically taking the blood and the solutions, the bicarbonol, we're mixing them together pre-filter, and the faster we move it through or the slower we move it through is how well or how quickly we clear a lot of the stuff in the blood system. So we can control that through the machine. We can control how fast we push the blood through. We can control how fast we're pushing the fluids through. And that's what allows us to say that it's the gentler dialysis. And what I always tell people is that this machine, although we have it in an ICU setting, will not do a lot of changes. And I think a lot of that will help kind of the body and it will help with blood pressures and all. So we slow down how fast we're pushing it through. We're not pushing as much blood through the system at one time, so we don't have as much blood leaving the system. So we're able to slow that down. We're able to drag it through the filter, pull everything out, put it back to the patient. That's how we're able to say that it's a more gentler dialysis. As I said, with hemodialysis, it's osmosis and diffusion. So what that means is that your fluids are going through the inside of the filter. Your blood is on the outside of the filter. And if we have a higher sodium, those are things we change, and it pulls it out, pushes it back in, but we don't control the blood flow rate on that one. Whereas convection, when I talked about just a little bit ago, basically what happens is we mix the blood and the fluids together pre-filter. It goes up through the filter, and then post-filter, it separates out. So you have your prismatate leaving the system at that point, and then you have the blood going back to the body. CRT, there's a couple of different types of CRT, but we'll talk about more CVVH. And you remember, this is 24 hours a day, 7 days a week. Unlike hemodialysis treatments, which are 3 to 4 hour treatments 3 times a week, we as the bedside nurse, we as a bedside provider will do this 24 hours a day, 7 days a week. So as you can see, a much slower modality, but once again, it doesn't do as much damage on the body, doesn't do as much damage on the vascular system as hemodialysis will do. Now, the one thing that we do is if your patient has a very high potassium, we will not use a CRT right off the bat. We will do hemodialysis. We will drop the potassium because you can't drop the potassium quickly in CRT. So we will do hemodialysis for a couple hours. drop the potassium, then at that point we'll switch them over to hemodialysis. The other good thing about CRT is we're dragging it through. We're not clearing as much. So when we talk about hemodialysis, they always talk about adjusting your antibiotics and stuff like that. You don't have to do that on CRT. You don't have to make any adjustments. You don't have to increase the amount or so forth that you'll have to do with the hemodialysis, because the hemodialysis will take a lot of that out at that point. The other thing with CRT is your pH and your electrolytes are going to remain stable throughout. So if you're acidotic, if you need to run bicarb, you're going to have to do that separately than with the CRT, because we're not going to be able to adjust that like we can do on hemodialysis. But once again, like I said, its main purpose is to slowly do this so we're not wreaking havoc on blood pressures and stuff like that, because the last thing you want to do is start decreasing blood pressures and then having to put them on pressors as well at that point. Like I said, there's different types of CRT therapy. There's the SCUF, or the slow continuous ultrafiltration. This is usually done over about a 12-hour period, kind of a cross between hemo and CRT. The majority of the time what we do is CVVH, which is that continuous venous hemofiltration. That is where your blood and your plasmacyte mix pre-filter, then they separate out post-filter. There is a way on this machine to also do CVVHD, which is hemodialysis, where you can put your fluids in post-filter, your blood in pre-filter, separate that out. But once again, if we wind up having to do CVVHD, we wind up just bringing the machines down and doing hemodialysis on them instead. So the majority of the time what we do with the next stage is we will do CVVH. Every once in a while we'll do SCUF, but the majority of the time it's CVVH. So what are our indications for CRT? Here in the burn world, it's always fluid overload. You know, we put a tremendous amount of fluid in these burn patients just to see how well their kidneys keep up. How well are we keeping up with what their third spacing and leaving the body at that point? But there's other indications that we run it for. When we start seeing acute renal failure, whether it's trauma, sepsis related, or whatever, we will use a CRT as well. The other big thing that we start putting them on is the sepsis. If their lactate levels are very high, we can run them on CRT. We can drag that blood through. We can pull out the stuff we need to pull out, the fibrogens and everything else. The problem that we run into with high lactic acids and CRT is that about every 6 hours, it tends to clog the machine off. So about every 6 hours, you're resetting this whole system up. Every once in a while, if we have a chronic renal failure patient that is either a burn, trauma, or something else, we will run chronic renal failures on CRT. I know their bodies are used to hemodialysis, but if their body's not able to allow for us to do hemodialysis, where we have to just keep going up with pressors and all this other stuff, we will actually put the chronic renal failure patients on CRT for a period of time before the body stabilizes back out and we're able to move them back over to hemodialysis. Now it says life-threatening electrolyte imbalances. I'd kind of like to take that one out because, like I said, if you have a high potassium, this is not the machine that you want to do it with, because you're just not going to be able to adjust their electrolytes in the time that you need to do it. So anything high potassium or so forth, we want to put them on hemodialysis. We will drop that potassium or whatever else we need to drop. And at that point, we'll switch them over to CRT. We've used it in drug overdoses just to kind of pull the toxins out. And a lot of times what we also will do on fresh hearts or fresh cabbages is we'll put them on for 24 hours. It will decrease the workload of the heart. give that time to stabilize back out, and then put them, and then go from there. So details of treatment. So next stage, like I said, continuous renal replacement therapy, CVVH, convection, not the hemodialysis or the osmosis and diffusion, which are all accustomed to seeing. Now, some of the complications that we run into with CRRT is bleeding. Bleeding can occur local or systemic. You know, we pay really close attention to INRs and so forth. Now, when we have those patients that have high INRs, we have those patients that are septic, that we're having issues with. What we have found is we can pre-filter run heparin, and so all we're doing is heparinizing the filter at that point. We're not heparinizing the patient. Post-filter, like I said, when things separate back out, the heparin will separate out with it as well. We will monitor the INRs about every 6 hours with this, but we have shown time and time again that running heparin through the machine, post-filter or pulled out, we do not change the INRs at the point people initially thought we would do it. Hypothermia is another big one. Now, I will tell you there is a warmer on the next stage that will warm the fluids going into the body. But once again, if you're taking blood out of the system, your patient tends to have an issue with hypothermia. Anytime we are pulling fluids, anytime we're doing all that, we always have to keep an eye on the electrolyte imbalance. So about every 6 to 12 hours, depending on who the physician is ordering it, we will pull CBCs, mags, and renal panels just because we want to keep an eye on it. Now, like I said, the CRRT will not change things dramatically, so you shouldn't see a lot of change in the patient every 6 hours when you're drawing these labs. As far as anticoagulation, we talked about heparin for a little bit, but the big thing with that is start keeping an eye on HIT panels. Are they starting to go into heparin-induced thrombocytopenia? Also, are their platelet counts low at that point? Now, it says argatroban. We've kind of gotten away from argatroban. We use sodium citrate if we can't use heparin at that point. And all we're using these for, if we're doing it to the patient, is if the machine goes down, we have to keep a way to keep that line open and not clotting off before we can get it reset up. So that's where the heparin and the sodium citrate and some of those come into play. Is we will heparinize the line. We will not heparinize the patient at that point. We'll keep the lines open. So when we do restart it, we're not having an issue with your double lumen dialysis catheters and so forth. Now, Prismasate, when we talk about Prismasate, the difference between CRRT and hemodialysis is on hemodialysis, you have your own separate acid solution, you have your own bicarb solution. With the Prismasate, everything is mixed together in one big bag. So everything's mixed together in one bag. It also comes in sterile water. So we do not have to have a water source for the Prismasate or the next stage. Like hemodialysis, where they hook them up to the osmosis, you go through the water to the osmosis machine to the hemodialysis machine. With the next stage, we don't have to have a water source because those bags are acid or bicarb, and they're also our water solution at that point. Now, when we hang bags, we hang 4 5-liter bags of this Prismasate solution. So we have 20 liters actually hanging of this solution. We tend to push the fluids through about 2 liters an hour. So on any given time, we have about 10 hours worth of solution before we have to reorder solutions and so forth. If we do hang solutions and our machine goes down after 24 hours, we have to discard the solution just because it's stable once you start running it for 24 hours after that. So that being said, let's go back to the CRRT, and this is our CRRT machine. when I talk to our nurses, when we go to do the initial training of the CRT, I always tell them that if you took the screen away, this is what home dialysis patients use to do home dialysis. And if they can learn how to do it, we can learn how to do it. It's really not that difficult. When I talked about the filter and the CRT, this is a CRT filter or the next stage filter. And if you look down below, everything goes pre-filter and then post-filter, it separates out. Whereas on dialysis, you have a connection here, you have a connection here. The blood goes in through the inside of it. The fluids go on the outside of it, downward, and pulls it off. Whereas this, everything gets mixed together. It goes through the filter. Now, like I said, the faster we push it through, the more it's going to clear, but we have that ability to adjust up and down depending on how stable that patient is and so forth. The other big thing with the difference between the two is on hemodialysis, you usually do 2 to 3 liters of removal in a treatment, depending on what their base weight is and what they're coming in weighing. So that's kind of based off of hemodialysis. Whereas the CRT, we will probably pull maybe even or 100 above. So in a 24-hour period of time, really the most we can pull off is about 2 liters of fluid just through this machine. So we really have that ability to slow it down. We have the ability to drag it through the filter, pull things out, bring it back to the patient at that time without really messing with blood pressures. Hemodialysis, you have about 350 outside the body as far as blood volume. With the CRT, you're about 210. So you don't have the volume that you have in hemodialysis where you're pulling it out, and if things go bad and we need to get it back and we can't get it back to them, it's not going to be as much as whether it would be in hemodialysis. But once again, if that machine goes down 2 or 3 times, we're probably looking at about 2 units of blood loss over that 24-hour period of time. So we're really mindful when we run the CRT. If we start having issues, really our big thing is to make sure we get that blood back to the patient. So we're not every couple hours or every 6 to 8 hours, machine's going down and we're losing that blood to where we can't get it back to the patient. The other thing with the machine is when we talked about it, the top number is how many liters an hour that we're running the fluids through. So when I talked about the Prisma state, when I talked about the 5-liter bags, this top number is going to control it. And we can do it anywhere from 1.5 liters an hour to 3 liters. If the body's able to withstand it, we start increasing it, because this is what's really going to clear it more than anything else, is how fast we're pushing that fluid through with the blood. The other thing with this, like I said, the bottom one, the blood, how fast are we pushing the blood through? So we try to push it about 250 mLs around. But once again, we could slow that down. We can increase it depending on the severity of the patient, how they're withstanding it. A lot of this right off the bat is trial and error, how well that patient is reacting to it. If we put them on immediately and we see that we're having decreased blood pressures, they're not going to kind of withstand what we normally would run it at. So we would slow the machine down. We would slow the fluid removal down. We would slow the blood rate down. We would give that vascular system time to bring stuff back in. That also being said is there are times, especially in burn patients, where we know that we're probably 10, 15 liters up as far as fluids. But once again, if that fluid isn't in the vascular system, we can't pull it off. So what we tend to do is if we start seeing a drop in blood pressures, if we start seeing that we're having to go up maybe on pressors or so forth, what we'll do is we'll drop the fluid removal down. We will give that time for the vascular system to pull things back in. And at that point, then we will start increasing the pull again. At this point, things like albumin, stuff like that tend to help because they will pull things back in the system. But once again, it's really, you've got to make the physician, you got to allow the physician to see that it's got to be in the vascular system to pull it off. If it's not in the vascular system, if they're third spacing everything, we're not going to be able to pull it off at that point. Fluid around the lungs, can't get that, other things you have to happen to fix that. The other thing with the machine, like when we talked about it, is we do have a fluid warmer down here, but that only warms the fluid. Once again, if your patient's hypothermic, this little machine, if you increase temperature, will not really deal a lot with the temperature regulations. All this is for the fluid. We will warm the fluid up, we'll bring it to them, which in a sense will raise it a little bit. But once again, especially with burn patients, other patients that are prone to hypothermia, you got to go to other measures and relying on this machine to warm them up at that point. We also have a drain on this. If you look right here, this yellow line right here is the drain. So when I said everything goes post filter and the dialysate and whatever else we're pulling off goes, separates from the blood goes back to the patient through the red line. The dialysate and all goes through, and then goes out this yellow line right here. Now, if we're running this at 2.5 liters an hour, the other big thing to keep in mind is that's not what that patient's truly getting, because that will come off post filter. The patient won't get that. A lot of times it looks deceiving on especially our charting, where if we're saying we're putting in 2.5 liters an hour, it's going to show up on our eyes and nose. The nurse at that point has to be mindful to take that off, because you're going to now show a very positive. So we have flow sheets that we will run. The nephrologists that are running the machines will look at that as opposed to our charting on the computer at that point. That will give you a better detail of how well we're doing. The two ways we can run it is we can do it on a fixed rate or a net rate. A lot of physicians like to prescribe the fixed rate. All that's saying is I know that every hour I'm going to set it for 200 an hour. If I am giving 100 of fluid intake and I'm taking off 200, that's going to give me a negative 100. That means that in a 24-hour period of time, if we can get it to continuously run, we will pull off 2,400 mLs of fluid, which is 2.4 liters. Not a big number in the big scheme of things, but once again, if that body's not able to withstand that pulling of fluid right off the bat, that's kind of what the machine's for. Is we're going to slow it down. We're going to slowly pull off fluids. It may take us a couple of days to get there, but we'll eventually get there. We don't have to do it over a 3 to 4 hour period of time, because if this patient is going on it, he's not going to be able to withstand that hemodialysis machine. And if they bring that machine in, they run it for 3 hours, and in the 3 hours we have to give them back 2 to 3 liters of fluid, then we've just defeated everything that hemodialysis machine was used for. So just a quick overview on CRRT. I know we're going to have another talk later on, acute versus chronic renal failure. Like I said, this machine tends to be more for the acute renal failure patients, and also preemptive type measures. Like I said, big burns that we know we're going to have to pull fluid off at some point because we are giving that much fluid at that point. Post hearts and so forth. a lot of preemptive sepsis. We talked about sepsis earlier. It works really good with sepsis. It's just we have to be very mindful that that machine is going to clog off probably about every 6 to 8 hours, just because it's just the fibrinogen and everything going through the filter is going to clog it off when your lactic acid is really high. So questions about this? Like I said, just a quick overview on the CRRT. It's a good machine, but once again, you know, when we're in an ICU setting where we want answers now, this machine's not going to give you this. This machine's going to take 2 to 3 days to give you answers. So be patient with it if you have to run it or they're running at that point, because you're not going to see the dramatic changes that you will see with hemodialysis. But once again, if we did do hemodialysis, the body probably just wouldn't be able to withstand it. So, questions? Anything that we can answer for you on it?